take a pause today and kind of just recap what we know about COVID-19. I think it's always good to kind of review periodically all of the things that the data have shown us and hopefully dispel some of the myths that continue to persist about COVID and often people's misperceptions about a lot of things about COVID. So we'll talk about what we know, and hopefully that will be a good refresher for all of us. So I have no idea what this movie is. I found this on Google, but it looked like an appropriate title. So, but apparently Time says moviegoers are enthralled. So the first thing to remember about COVID is that it is a highly transmissible respiratory virus, and it's changed over the course of the pandemic to become more transmissible. If you look at this graphic that compares the relative baseline or basic reproduction numbers of the viruses, you'll see that down at the very bottom, COVID Wuhan, that's the original virus that arose out of China, had a transmissibility that was relatively similar to seasonal influenza and the common cold. But as you look across time, as we had new variants that popped up, first Alpha, then Delta, then Omicron, and now BA2, those viruses have increased in their inherent transmissibility quite significantly. And now with BA2, we have a virus that has a transmissibility that is on par with some of the more transmissible viruses that we know of, including chickenpox and polio. And so, looking at that relative scale, you can see that we are at a level 3 to 4 times the transmissibility of the original virus that emerged out of Wuhan, perhaps even a little bit more. And so that explains why countries that were able to contain and suppress transmission of COVID-19 previously have been unable to do so with BA2. And you just need to look at places like Hong Kong and mainland China and Taiwan and other countries, Australia and New Zealand, that had done so well. And they are just not able, without essentially locking everybody in their home or apartment to control the spread. But it doesn't mean that you have to have the morbidity and mortality associated with an outbreak if you have good vaccination rates, and we'll talk about that later. The second thing to remember, the lessons that we've learned, is that I think we had this idea early on that herd immunity was kind of this static phenomenon. You would continue to accrue cases, but when vaccine came, you would continue to build immunity through vaccination. And once you reached a certain level in the population, you were done. The virus could not propagate anymore, and the pandemic's over. I think, unfortunately, we've learned a couple of things. First of all, that immunity from SARS-CoV-2 is temporary and transient, and we knew this about other coronaviruses, so we shouldn't be surprised. The closest relatives of SARS-CoV-2 that circulate in human populations frequently as causes of the common cold are viruses that people get constantly reinfected with throughout life. So we knew that immunity against these individual viruses was not necessarily long lasting. The other thing is that we realized that as new variants arose and the virus changed, it was able to escape to some degree, more or less, immunity from previous infection and even vaccine. And so as time goes by and the virus changes, it requires continued boosting of immunity, either through reinfection or preferably through vaccination, where you don't buy all of the hazards of natural infection to be able to maintain the level. And so we shouldn't be surprised then, looking across the population, that in Nebraska, for instance, if you look at blood donor surveys from the CDC, and these data are only good through December, so that omits data from really the Omicron wave at all. But even at that time, essentially 94% of Nebraskans at that time had serological evidence of previous infection or vaccination. If you look at the laboratory surveillance data, so this is where CDC looks at blood from all sorts of blood draws for laboratory tests having nothing to do with COVID, but then they run antibody tests on those. And they found that, again, in January, before the impact of the Omicron wave could be seen, over 50% of Nebraskans had serological evidence of actual infection with a SARS-CoV-2 virus at some point in the past. So that is, again, before the impact of Omicron, and understanding that antibody levels wane over time, as we know immunity does. So if you look at the total data across the pandemic for Nebraska, you can see that there was a point there in January of 2021 where we peaked in antibody levels. And that percentage of people with detectable antibodies actually went down over the next 6 months quite considerably, less than half. By the time we reached July, had antibodies compared to where they were back in January. So this shows that over time, many people lose those antibodies as they get further and further out from either vaccination or natural infection. This is actually from natural infection because these antibodies detect only antibodies that you could make against infection with a natural virus. So, and that appears to happen more commonly in people as they get older, which in some ways explains why we see the seroprevalence for age 65 and above is much lower. But also, I think it's true that, as we've discussed previously, young people are the ones who are out and about and have the most social contacts on an average daily basis. So they are infected more frequently than adults are, and that's reflected in those serological surveys as well. You can see that kids under the age of 18 actually have the highest antibody prevalence of anybody in our community, and I think that again is just a function of kids are in school for many hours a day in the most densely populated area of any community, and thus are more susceptible to actually get infected and transmit infection. And we know that that's the case from many studies now. So the reality is, even by January, almost everyone in Nebraska had already been infected with COVID-19 or been vaccinated, or probably both. And if you look at, kind of a reasonable estimation based on antibody decay rates and everything else, at least 3/4 of Nebraskans have actually been infected with COVID-19. And so we already had achieved that kind of theoretical herd immunity threshold a long time ago. The issue is that immunity wanes over time, and that's why we require periodic boosting to get immunity in the population up to a level which can really control transmission and reduce morbidity and mortality. The next thing we know about the virus, and we've known this for a while, is that it is transmitted by air. It is transmitted by droplets of different sizes that can travel different distances. As you get closer to somebody, you potentially pick up these larger droplets that are 5 microns, 10 microns, 20 microns in diameter, that actually fall out of the air over a short distance because of gravity. And so that probably gives you an increased risk of transmission the closer you are to somebody. But we know that these droplets that are smaller than 5 microns can travel long distances in the air. They behave like gases, and they are responsible for a large amount of the transmission that occurs. And we also know that this transmission often occurs, and probably in the majority of cases occurs, from folks who do not have symptoms at the time. Either they are pre-symptomatic, so they are infected, they are shedding virus, but they have not developed symptoms yet, although they may go on to develop symptoms in the next day or two. Or in some cases, we know that people who never develop symptoms still shed large amounts of virus and can infect other people. And so for this reason, because the virus is spread primarily by air, not by direct contact, not by contact with surfaces that somebody's touched, although that is possible, but because it is primarily shed by air, we know that these things like wearing a face mask and improving ventilation in indoor environments are critical steps to reduce the risk of transmission. Obviously, hygiene, washing hands, cleaning high-touch surfaces also help, but they do not have the impact that these other steps that reduce transmission by air will have. We know also that the virus does not spread evenly or homogeneously through a population. So even though we say, potentially right now, let's say the effective reproduction rate is 3 for a community. So that doesn't mean that everybody who's infected infects 3 other people. It means on average, those people may infect 3. But the reality is it's a small subset of people with COVID-19 that go on to spread the virus. And it happens in these super spreader events. So in the graphic on the left, you see that infected individual went on to infect a large number of people, 10, right? But out of those 10, only 1 went on to be kind of a significant super spreader and spread it to a lot of people. 1 person spread it to 2, and 2 people spread it to 1, and the rest spread to nobody. And that pattern repeats itself over multiple generations. And as a result, this kind of general rule of thumb that data that studies have shown is that about 10% of people with COVID are responsible for about 80% of the transmission events. And this is why the virus behaves differently from some other respiratory viruses, and why things like reducing crowds and crowded environments is so important, because you want to take away the environments that lend themselves to these super spreading events, such as crowded indoor environments. And that's more effective for COVID potentially than it is for other respiratory viruses. We also know the impact of COVID-19 has been huge across the country and in our state, sadly. We know that we're approaching 1 million deaths nationwide of confirmed cases of COVID-19. And as we've discussed before, the true number of cases is probably quite a bit higher, probably at least 10 to 20% higher based on excess mortality data. In Nebraska, we've lost 4,200 souls to COVID-19 since the beginning of the pandemic. And that means 1 in every 468 Nebraskans has died of COVID-19 since the start of the pandemic. So think about that for a minute. If you live in a town of 2,000, on average, 4 people in your town have died of COVID-19 since the start of the pandemic. That's a huge impact, right? And in a town of 2,000, you know everybody in that town. So across Nebraska, almost everybody knows multiple family members, friends, relatives who've died of COVID-19, and the impact just in deaths is obviously dramatic, but the impact goes well beyond that. And it also goes beyond these high risk groups that people often think about. We often hear discussions of, well, it's really only the old, or it's really only people who have significant comorbidities who die, but the data don't bear that out. And what's been even more interesting is if you look over time as the pandemic has evolved, the risk of dying for those people who are young and have lower risk factors has actually gone up. So these are data that were just released by the CDC and MMWR a couple of days ago, and looked at mortality rates from COVID between 2020 and 2021. And what's interesting to see is that if you're 75 years or older, your risk of dying of COVID actually went down between 2020 and 2021, so decreased by over a quarter. And the reason for that, I think, is obvious, because our vaccination rates among the elderly are much higher than they have been. Or, obviously we didn't have people vaccinated until the very end of 2020. And over 2021, we did a good job of vaccinating folks over the age of 65, and particularly over the age of 75. What's interesting, however, if you look at those age groups of people younger than age 45, and that includes people under the age of 24, if you're in that category, your risk of dying from COVID has doubled between 2021 and 2020. And I think it will go up even more in 2022, unfortunately. And the reason is, again, this group has very low rates of vaccination and have had many more infections compared to the year 2020. And so even though we talk about, the new variants are mild, again, the data don't bear this out, because if you're a young person, your chance of dying from COVID has gone up over the course of the last year. If you're in the older category and you've probably been vaccinated multiple times, then yes, your risk has gone down and the viruses look milder to you. Although again, from an absolute number, we're still losing a lot more people over the age of 75. We also know that the risk of COVID needs to be looked at beyond just the lens of mortality, of deaths. We know that there are many long-term consequences of COVID, and more are popping up every day. Some studies have indicated that as many as 50% of adults who've been infected with COVID have some symptoms of long COVID after infection. Most studies put the number somewhere between 10 and 30% for adults having significant symptoms at 3 months or 6 months or even longer. that would meet the definition of long COVID. And the rates in children are not much lower, right? Most studies have a rate somewhere between 5 and 15% of children exhibiting symptoms several months after acute infection. We also know, and we've talked about a number of these studies, that more and more data indicate that there's a dramatic increase incidence of many other underlying medical problems after COVID-19 compared to controls. So people who've had COVID-19 within the last year have a higher rate of diabetes in the year after they have recovered from COVID. They have a much higher rate of heart and vascular disease. They have a much higher rate of kidney disease. They have a higher rate of neurological and cognitive deficits, and they have a higher rate of mental health disorders. And for all of these, there's an increased rate of hospitalization and seeking medical care for all of these conditions. So we know that beyond, even if you don't die, you are left potentially with long-term consequences after COVID-19. And this is going to have, I think, a significant impact on our health system for years to come, as we're left with the burden of caring for all of these patients. And anybody who's been in and around the hospital, even this week, knows that even though our COVID numbers are really low, our overall census is still incredibly high. And in part, that may be because of all of these complications we are seeing from post-COVID infection. We also know now, I think, with complete certainty, that the vaccines we have for COVID-19 are safe. They have safety profiles that are similar to most other vaccines that we use on a routine basis. And to be honest, we've used more doses of these vaccines than many of these vaccines we use on a routine basis. Over the pandemic, we've now administered over 11.5 billion doses of COVID-19 vaccine across the world. In North America alone, almost 1 billion doses of COVID-19 vaccine have been given, and almost all of those in the US and Canada and Mexico are mRNA vaccine. We know that the side effects that we've seen occur at a low rate, and again, comparable to other vaccines. We know that there's some elevated risk for things like myocarditis, particularly in young males, given one of the mRNA vaccines. We know that there's an increased risk of Guillain-Barré, seems to be in older males, given one of the mRNA vaccines. And we know that there's an increased risk of blood clots, primarily in women of childbearing age who've been given the Johnson & Johnson vaccine in the US or other adenovirus vaccines worldwide. But for all of these complications, the risk of these complications from vaccine is still much, much, much lower than the risk of these exact complications from getting COVID-19. And then throw in all of the other morbidity and mortality issues with getting actual infection with COVID-19. And again, the risk-benefit ratio, I think, is really indisputable, that the risk of getting COVID far outweighs any risk of the vaccine, and the benefit you get from reducing risk of COVID with the vaccines makes any risk of the vaccine totally worth the calculation. We also know that these vaccines continue to be effective in protecting folks from COVID-19, even with new viruses like Omicron and BA2. And especially once people are up to date. We know that vaccine effectiveness wanes over time. We know that effectiveness wanes over time more quickly for some of the later variants like Delta and Omicron. And again, that's because the virus has drifted away a bit from the original Wuhan virus the vaccines were made against. Nevertheless, these vaccines still remain incredibly effective at reducing hospitalization and death. And you can see that after a third dose, Delta and Omicron vaccine effectiveness rates are similar, and they are 90% or greater in preventing hospitalization. That's a great vaccine. We also know now data that have come out of Israel and other studies looking at fourth doses indicate additional benefit, especially for those who are in high-risk groups over the age of 50 or with other comorbidities. So again, the vaccines are safe and the vaccines work really well, but you need to be up to date on your vaccine status to get the most benefit. And across populations, we've seen very clearly, and again, I've talked about this multiple times, populations and countries that have high rates of up-to-date vaccine status, so adults who've had a recent booster, have much greater decoupling between cases and hospitalizations than countries that don't. And that's why in Hong Kong, we saw high rates of hospitalization and death because they have relatively few people in the high-risk groups that are vaccinated and boosted. Compare that with Taiwan, which is having a huge BA2 outbreak right now. Their death curve has not moved at all. And that's true for other countries that have high boosting rates like New Zealand and Australia, South Korea, and others. So if you are, as a population, highly vaccinated and you have a high percentage of your folks boosted, particularly in the high risk group, you're going to do just fine, even with a very large outbreak where multiple cases occur. And so we know what interventions work besides vaccine to reduce transmission in a community. And this is due to the fact, again, that the virus is highly transmissible. It's transmitted by air, and it transmits primarily by super spreader events. And so very early on in the pandemic, and again, I think this is something we've talked about a number of times, Japan adopted this 4C or 3C strategy. The 4C, fourth C that I include is cover your face with a mask. But the 3C strategy that Japan adopted was avoiding closed spaces, avoiding crowds, and avoiding close contact. And when Japan implemented this strategy across the population, they had very low rates of transmission for a long time, and then were able to finally vaccinate a large proportion of the country before they had many infections. That fourth C that I talk about again is cover your face. And we know the data are quite clear in showing that face masks have a significant effect in reducing transmission, not only for individuals, and this study looked at individual risk based on whether you wore no mask, a cloth mask, a surgical mask, or an N95 or KN95. But we know multiple studies now show that across communities, when you have high rates of face mask wearing, you reduce transmission significantly. And that makes a lot of sense. We know that it's not just the individual potential recipient of virus for whom masks work. They are actually more effective in reducing shedding from a source, particularly sources that may be asymptomatic and shedding at the time. And when you combine those effects, so everybody in the community is wearing a mask so that you're reducing shedding, and because everybody's wearing a mask, you're reducing the odds that somebody who's susceptible is getting inoculated with high numbers of virus particles that can cause infection. That's why you get dramatic reduction in transmission across populations when you have wide adoption of face masks in indoor environments. So that's a quick summary of what we know, what the current data tell us. And from, I think, those data, it's pretty obvious what we should be doing over the next month or two and over the next 6 months to get ready for this BA2 wave that's here, and the next wave, which will inevitably occur in the summer or fall. But it's obviously up to us as a community to do those things. Thanks.